Assalamu alaikum and good evening. Respected physicians, this is our 99th session of ECG study group regular presentation, basic and beyond. And today our presenter is Dr. Abu Mohammed Shafique, consultant, United Hospital Limited. Before start of the session, I'd like to request Professor Abdul Jamil sir to introduce Dr. Abu Mohammed Shafique sir, and then we start the session. I'm requesting Professor Abdul Jamil sir to introduce Dr. Abu Mohammed Shafique sir, and then we start the program.
Thank you, Tushar. Yeah. Shafique, Dr. Shafique is younger brother of my medical college. He is 3 years junior to me, and he is sincere since I know him from medical college. Again, he was my direct student in MD Cardiology in BSMMU while I was assistant professor there. And I know him, he's very talented, hardworking, and honest person. And he's a knowledgeable person. And I wish him good success. Shafique, please carry on.
Thank you, that is a very huge for me. You have just told. I'm not that much. I'm really a very simple cardiologist. Can you hear me?
Yes, sir.
Okay. I can start right now, right? Here, today I am going to present some simple cases, actually simple ECG. Actually, this is definitely for the fellows. Maybe so many fellows are with us. So we need to discuss, not to teach, rather than I want to learn from the discussion as well. And I just want to learn. This is actually learning curves never ends. So at OPD, I got a patient of 63 years, patient diabetic hypertensive, and previous history of PCI outside the country. He has since then occasional vertigo, and there is no syncope history still, and previous history of bradycardia long been, and during the procedure he had bradycardia as well. But this time he has pulse 32 beats per minute, blood pressure 130/70 millimeter mercury in my OPD chambers. And this is the ECG. So I got the ECG, and right, you have seen the ECG. And for the fellows, what could be the diagnosis? Is it a sinus bradycardia or junctional bradycardia, Wenckebach's phenomena, complete atrioventricular block, or none of the above? Is there any voting system here?
Kamrul bhai, please start poll.
Sinus bradycardia, A, B, C, but there is no D. So we can go for some discussions here. If I go back into the previous slide, so look here again. I think its heart rate is very regular, ventricular rate, and it is a sinus bradycardia told. So can I get some comments from the from my teachers?
In this ECG, if you look at the lower panel, the rhythm strip, the first complex does not have any preceding P wave. The second complex has a small P wave with short peer interval without delta wave. Third one looks like normal. Fourth one, little bit prolongation of peer interval, but it is within normal limit, as well as the last one. Difficult to comment.
Shafique,
Yes, sir.
may I comment?
Sure, sir.
No, I think the PP intervals are fixed as well as the RR intervals are fixed, but the PR interval are not fixed. That is the
Peer interval variable little bit.
variable PR interval. So the complete heart block should be considered first.
Right, sir.
Yeah. In the first
And-
complex, probably the P wave fall on the
Just after the R wave.
just after the R wave.
Right. So PP interval is fixed and RR interval is fixed. And
And
PP interval is
rates are probably nearest atrial and ventricular rates.
right near to, but so in this ECG, my diagnosis is sinus bradycardia with complete heart block.
How it can be?
Sinus bradycardia with complete heart block.
Oh, okay.
So this is when actually I just stuck with sometimes what could be the ECG diagnosis. Later on, I could see there is PP interval is fixed, RR interval is fixed, but no relation. So it should be complete heart block. But PP interval is again rate is around 30 PP interval, RR interval around 32. So it is sinus bradycardia as well.
I will disagree.
Oh.
When
Yes.
we talk about sinus
It's easy
tachycardia
of
or
debate,
sinus
should be.
bradycardia, we usually mean that the sinus node is driving the heart. But when the sinus is on its own, the ventricle is on its own, we do not talk like that. We could say the sinus rhythm, the sinus beat is beating is at a lower rate, and there is junction and escape rhythm because the complex is narrow with a heart rate of so and so. But we could not say that complete heart block with sinus bradycardia. That's actually not the norm.
No, sir, I just want to differ with you because sinus bradycardia means sinus rate is low, but there is a complete heart block. That is why there is no relation between P and R.
Shafique,
Sinus rate.
when we talk about cardia, we actually mean the heart rate means the ventricle rate. Ventricle rate.
Right.
That's the point.
But
the ventricle rate is not that.
P rate is, but
And ventricle is not driven by the sinus node.
Yeah. Should in other way, whether we can say it is reduce atrial rate with complete heart block.
You can say that, but you cannot say this is sinus bradycardia. At least the heart is driven by the sinus node. It's not.
But I have gone through few slides in the internet. It is said that it is sinus bradycardia with complete heart block. This type of ECG, I have gone through few ECG. So they defined as it is a sinus bradycardia with complete heart block.
Sir, this dissociation is because of the extreme sinus bradycardia.
Right, extreme sinus bradycardia.
Extreme sinus bradycardia resulted in escape rhythm coming out from the ventricle. So the ventricle is running its own, and the sinus, because of extreme sinus bradycardia, the impulse is not reaching the ventricle. So the ventricle itself producing the impulse. So there is the dissociation is because of extreme sinus bradycardia, not because of AV nodal problem. Is it you want to say, sir?
If there is AV nodal, if there is no problem, there should have some capture bits. It is in that case, rhythm would be irregular.
স্যার আমরা যদি পরের তিনটা দেখি, মানে লাস্ট এপিসোডটা যেটা দেখি, লাস্ট কিউআরএস যদি দেখি, তার আগের পিএফটা যদি দেখি, and the PR interval of that QRS and PR interval before that QRS is almost same.
But not same, nearly same. But in the previous QRS complex, there is P is there, but not same, right? So altogether, if we put in single diagnosis, so it should be extreme sinus bradycardia with complete heart block. But definitely it is a ECG of debate. I am not confident in my diagnosis still.
Sir, I'm requesting both Atahar sir and Wadud sir. Sir, can you put your observation or diagnosis in this ECG?
Is there any further discussion? If not, then I can go for next.
Ajit sir, please have your comment.
হ্যাঁ,
please.
আমি সরি, আমি অ্যাকচুয়ালি ক্লিনিকে আছি, একটা ফ্রি ক্লিনিক এই মুহূর্তে, বাট এনিওয়ে আই জয়েন্ট লিটল বিট, let's see if I have time to watch more. But I do agree with that. There's baseline under sinus bradycardia is there. There's looking at the atrial rate and they're marching together. Okay, but the question right now, yes, there's a dissociation there, but yes, sinus bradycardia itself can be by itself, and AV dissociation could be by itself. That is true. But sometimes we see isorhythmic, rhythm, but that time the sinus rate and ventricular rate pretty much similar, but they have dissociation. But here the ventricular rate probably a little bit lower than the sinus rate, but you have to march it to see that.
Thank you. Then we can go for next ECG.
Sir, please carry on for the next ECG.
Okay.
Now, Shafique, what treatment you suggested for that patient?
Oh, I already suggested for rate is too low, 32. So I advised him for pacemaker implantation, definitely double chamber pacemaker. But patient are taking time because he has previous bradycardia. In that period of moment, he treated outside, and they told them you don't need any pacemaker right now. But that time bradycardia was not less than 40. That time our rate was more than 40. But this time rate is really low, 32. That is why I suggested him for pacemaker implantation. But patient was thinking not yet come still, and he's actually a bit differing my opinion.
So again, what is your idea? That is, it is a AV nodal disease or AC nodal disease? Shafique, please.
It is basically AC nodal disease. This is 6 syndrome. And 6 syndrome may degenerate into complete heart block as well. Definitely sinus nodal disease is there. Otherwise, extreme sinus bradycardia is there. Sir?
I think there's a question right now, it could be both, because reason is sinus node disease itself is confined to that. But if sinus bradycardia, sinus node disease causing the bradycardia, then we should not see complete heart block, because the patient probably have both sinus node and AV nodal disease.
Right, sir.
True.
Otherwise, why would you see complete heart block?
So there is no evidence of avinodal contraction, right?
Right, sir.
So thank you, Shafique. Excellent ECG.
Thank you, sir. This is ECG I have seen just yesterday. I got this ECG yesterday. So this is very nascent ECG I'm showing. I got the ECG yesterday in a patient in surgical ICU. So what could be the diagnosis? Hyperkalemia, hyperacute myocardial infarction, normal variant, or none of the above?
Poll, please. Dear participant, comment please. Hyperkalemia है. So good number of
Maximum in favor of hyperkalemia. So actually, this one point, it is really difficult for me to go into diagnosis in my patient. Patient was in ICU and has I'm going female, 49 years, and decompressive craniotomy done because of intracranial hemorrhage. Patient hypertensive diabetic. Initial troponin was 2546, later on it decreased. Today it is 1532, and NT-proBNP was 25,000. Potassium level 4.5, and today it is 4.7. Echo done, LA a bit dilated, moderate concentric LVH, E by E prime 15. So then what would be the diagnosis actually? It is not in favor of acute myocardial infarction, not in favor of, definitely potassium level is normal, definitely. Then is a point of discussion, such.
So back to your ECG again, please.
Usually cerebral T means deep T inversion. Here it is hyperacute like T waves, very prominent T waves. But could it be a variation of adrenergic toxicity because of the stage the patient has undergone for craniotomy?
And another question is the patient having any symptoms?
Actually,
that
patient is in
time?
ventilator, and
Oh,
the
okay, so on
decompressive
ventilator.
craniotomy done because of intracranial hemorrhage. So
Mhm.
patient female, blood pressure, she was in antihypertensive medication, including IV GTN. NT-proBNP was higher. So
yeah,
actually,
normally
I could not fit this because I have seen the her previous ECG. This is 2 days ECG. 2-day ECG comes to normal, and this is her previous ECG before surgery. So this is really difficult. How can I put the diagnosis? It is hyperkalemia or hyperacute myocardial infarction. And then I went one papers. It is published in 1967, where it is told that in cases of left ventricular hypertrophy, the T waves are tall from V1 to V4 in systolic, that is pressure overload, and from V4 to V6 in diastolic, that is volume overloading, and from V2 to V6 in combined types of overloading. Here, patient having hypertrophy, as well as patient having volume overload, as well as pressure overload. So here, definitely it fits well with this scenario, I do believe.
Now, I have one question right now. Was there any evidence of volume overload when you examine the patient? Because patient's ICU, was there any JVD elevation, lungs crackles?
Patient having
and-
lungs crackles, patient NT-proBNP was 25,000
Mhm.
and pressure was higher. Patient was on GTN IV to reduce the blood
Mhm.
pressure and also getting some other antihypertensive medications orally.
Shafique, can you back to the ECG again? Aziz bhai, actually, this is the tall peaked T wave with wide base, and both the limbs are almost symmetrical, though ECG satisfies the criteria of the ischemic T.
Right, sir.
So it excludes the, that is the hyperkalium is excluded because of the wide base and symmetrical limbs. So hyperkalium is excluded, but possibility is it is ischemia related, not necessarily the ST elevated MI. As the patient, the patient is unconscious and the ventilator, the troponin is raised. Can it be due to the some kinds of the ischemia related? As because there is the, that is the LVS related T should not be like this. There should be other criteria as well as the T wave, that is the R wave changes. So in
No,
absence
that-
of the R wave changes and STT changes, only T wave cannot satisfy the criteria for the LVAs.
And
So,
there's a possibility of, if it's endomyocardial ischemia, because the reason is if there's a significant elevated high blood pressure, that firstly, it can cause some pressure in the endocardium. But a lot of time we see some ST depression there, but it's not unusual to have any, if it is ischemic cause, if it's early ischemic cause, it's a possible because of the high pressure and volume pressure overload is possible. We cannot exclude that. But normally we see this type of thing in early manifestation of transmural ischemia if it is widely spread pressure inside the endocardium. That's a possibility. We cannot exclude that. Because I agree with that, because it's wide based and not narrow peak, it doesn't look like hyperkalemic, T wave. Pressure overload and significant endomyocardial ischemia because of the pressure overload, it cannot be excluded. Since it's reversed and we didn't see any before, it's kind of transient event. That's quite possible.
this T wave persisted for few hours. Even we have done some serial ECG. T wave gradually reduces to normal. Today T wave is normal. Yesterday 2 more ECG was done. Still T wave was there. Peak T wave was there, and that was reduced a bit. And moreover, his heart troponin level reduced from 2500 to 1500. It did not increase. So, so ischemia ischemic cause in that case can be ruled out.
The one question right now with this TUF, normalization over time, did it correlate with the better blood pressure control and volume control?
Today blood pressure is 110, 108 by 64, 64, 65, something like that. Less than 110 by 70. Today, she's on arterial blood pressure monitoring. We did not do the NT-proBNP today again, but her previous NT-proBNP was 25,000 day before.
Sir, can it be due to transient ischemia, as you said, due to high blood pressure at that moment, which reduced after using GTN and other antihypertensive medication?
Right.
But the point is, Tushar, usually when there is pressure overload, we have T inversion. When we have volume overload, we have T upright T. It doesn't add up. We do not have clear explanation for all these changes. But this is a very beautiful example of the enigma that the ECG presents to us.
Because sometimes we see this type of changes when they're a little bit tachycardic, but the patient is not tachycardic.
Right. Patient is not tachycardic. Actually, but this is really embarrassed me. I could not fit the ECG in any way.
Mhm.
But I was totally curious whether patient having ST elevation. In the meantime, I was just
Mhm.
following the patients and having the ECG by WhatsApp, and there is no ST elevation there. And they send me 2 more ECG where there was no ST elevation, where the T wave is going down. So we can move to the next ECG, sir. '65 male patient, diabetic, admitted in general HDO, diagnosed as pneumonia and developed bradycardia. That is why they asked me to see the patient. I have seen the patient, and this is the ECG.
Emma?
So it's actually, this is a very simple ECG, but I put it here for some reasons. So diagnosis, whether it's complete atrioventricular block or 2:1 secondary AV block or none of the above.
ECG গুলোর সাইজ বড় হলে একটু সুবিধা হতো।
Previous ECG is fine. It's bigger.
Thank you. Thank you.
300, 150, 175, 60।
So it is 2:1 block. This is really difficult for many. It's the maximum participant told it is 2:1 block. But if you look into deeply, then you will understand actually what it is.
Shafique,
Yes, sir.
it's not 2:1 AV blocks.
Definitely not.
It's a sinus bradycardia with prominent UA.
Correct. And that is, thank you, sir. And that is why, what investigation do you suggest then? It is for the fellow, think about, it is usually happen in case of hypokalemia and patient having 2.9 potassium level.
Okay. But it can be in normal variant also.
Normal variant as well. But in that case, not that much bigger U wave. Here, U wave is near to T wave and more prominent in the V2, V3, more prominent. V3 is more prominent. V4 as well. So, bradycardia with, then I just asked them, what is the potassium level? They told me it is 2.90.
Potassium was
2.90.
calcium.
Then potassium, the potassium correction, they've already been started. But bradycardia, then patient improved. Bradycardia was.
How was calcium?
Calcium level, I did not see the calcium level, but they did not do the calcium level, but potassium level, I got the potassium level 2.9. So I asked them to correct the potassium. Then I did not give any sorts of medications for bradycardia because bradycardia was not that much.
Yeah.
ওই তার এবিজি থাকলে এবিজির মধ্যে কিন্তু ক্যালসিয়াম লেভেল পাবে।
এটা অ্যাকচুয়ালি জেনারেল এইচডিওতে ছিল পেশেন্টটা, সেই জন্য আমরা মানে যেহেতু অবভিয়াস পটাশিয়াম লেভেল ইজ দেয়ার and patient quite communicating, পেশেন্টের কোনো এরকম কোনো সিমটম সেরকম কিছু ছিল না, কোয়াইট গুড কমিউনিকেটিং, সেই জন্য আমরা ফার্দার কোনো ইস্যু চাইনি।
Shafique, can you show the ECG again?
অ্যাকচুয়ালি আমিও কয়েকজনকে ইসিজিটা স্যার দেখানোর পরে আমি কেন এটা দিলাম সেই বলি স্যার, ওই সবাই 2:1 ব্লকই ম্যাক্সিমাম বলছে স্যার। আমি যে কজনকে দিছি স্যার সবাই 2:1 ব্লক বলছে স্যার। এখন ওই এটা অতখানি ভালো করে খেয়াল করে নাই তো এখানেও তাই হয়েছে স্যার, ম্যাক্সিমাম 2:1 ব্লক বলছে। এটা আমি সেই চিন্তা করছি যেটা এরকমই
এখানে 2:1 এর এগেইনস্ট দ্য পয়েন্ট যেটা
পিপি ইন্টারভেল।
UF simulating P interval. PP interval is not regular then.
রাইট।
Hmm?
In that case, PP interval would be
Regular.
হবে না। আর ইউ ওয়েভ আর পি ওয়েভের মধ্যে মরফোলজি ডিফারেন্স আছে।
Morphology different.
মরফোলজি ডিফারেন্স।
Okay. Next, Shafique.
যাবো স্যার।
হুম
83 years male, ex-smoker, hypertensive, patient having COPD with pneumonia and also non-STMI and LVF, admitted in CCU and got the ECG. So diagnosis, what could be? It's a complete atrioventricular block, atrial flutter with 3:1 block, atrial tachycardia with 3:1 AV block, atrial flutter with 2:1 AV block, or none of the above.
Kamrul bhai, start poll, please.
আচ্ছা, can you enlarge the ECG please?
Previous slide. Shafique.
In clinical practice, anyone would be able to diagnose the case, but in case of examination table, it is difficult to answer. But in clinical practice, it is very easy to diagnose because you will get more other things to diagnose the case. So I'm going to that part because there is variable answers. No one can get the conclusions.
Shafique, show the questions.
Questions was complete heart block, atrial flutter with 3:1 block, atrial tachycardia with 3:1 AV block, atrial flutter with 2:1 AV block, and none of the above. Actually,
It's none of the above.
none of the above, right, sir? This is none of the above.
Complete atrial tachycardia with 3. No, Shafique.
Yes,
Whether
sir.
whether the patient is on TPM.
Yeah.
Right, sir. Patient is on
There
PPM.
are pacemaker.
Pacemaker.
There are pacemaker spikes.
This is pacemaker, is a double chamber. Double chamber patient is in atrial tachycardia and mood switching to ventricular mode. That is why ventricular pacing at
V1.
its own rate, and atria is not pacing, not sensing even because of mood switching. So this is the interrogation.
Can you show the ECG again, please?
In the rhythm strip, there are spikes. Before
Spike is there.
most of the QRS complex.
A spike is there. So one need to see the spikes as well. But in clinical practice, it is easy because patient having a pacemaker, one know and see the X-ray, then definitely. And here the atrial rate is around 230 atrial rate. So it is atrial tachycardia.
True. This is atrial tachycardia with
Mode switch.
pacemaker. That is the VVI pacemaker.
VVI
Pacemaker is working in the VVI mode.
Right, sir.
Thank you.
68 years male, non-diabetic, non-hypertensive, intubated after resuscitation from cardiac arrest after getting injection of verapamil. Actually, this ECG not in our hospital. This is outside the hospital, where patient having this ECG and patient was treated with verapamil and reverted to sinus rhythm. And then patient again developed symptoms and patient come to our emergency department and got the history. Patient got verapamil in another center and returned to sinus rhythm. That is why our emergency department given verapamil and patient went into cardiac arrest and resuscitated, intubated and sent to CCU. And this is his previous ECG. So what is the diagnosis? I did not put any poll here. Actually, can be discussed.
So can you mention the blood pressure before giving the verapamil? That is what is the blood pressure of the patient before giving verapamil?
Actually, I did not see the blood pressure. It is done in emergency department, and actually patient come to ECG intubated. Blood pressure at that period of moment, patient was in sinus rhythm, and this was the ECG in CCU. And this patient was intubated, and blood pressure at this moment, blood pressure patient was on inotropic support as well.
No. Shafique, I want to know the scenario. That is, the patient was brought conscious.
Brought conscious, and probably
then verapamil given and arrest developed.
Arrest developed.
Then intubated.
Then CPR given and intubated. CPR probably they have given CPR around 15 minutes.
So they did not try with adenosine, no?
They because previously patient got verapamil. That is why they choose verapamil first.
Okay.
Yes, sir.
This letter ECG, that one with bradycardia. Yeah. It seems ectopic atrial rhythm near about around atrioventricular ring.
True. Jamil, true.
Yeah. As because there are inverted P waves in inferior leads.
Inferior leads, right.
True. Shafique, one explanation maybe that is either the patient had got the baseline hypotension before giving the verapamil, or all the patient already that is got the verapamil, and again giving the second shot of the verapamil, patient may develop the complete heart block. These two may be the explanation for the cardiac arrest and thereby intubated.
That could be the actually I was not there.
And this is the junctional, that is the escape rhythm, that is the what Jamil says. That is and this is again in favor of the complete heart block that patient may develop, as because this is the junctional escape rhythm. That is atrial escape rhythm.
Junctional escape rhythm, right, sir.
Jamil?
Yeah. Ectopic rhythm is from atrium near to the
atrial. That is the escape rhythm. The escape rhythm from the atrium.
Yeah.
And another thing is, sir, whether R wave is slurred, B3
not much.
A bit slurred. B3 a bit slurred. B4 a bit slurred.
Not much.
But these are the escape rhythms, so that is a direct comment is not easy, as because these are the escape rhythm. That is the STD changes may not be truly significant, as because these are the escape rhythm. But there is some changes definitely without the.
Okay, sir.
So what is your question? That is regarding the previous ECG. That is what is the mechanism of cardiac arrest? Is it?
Patient developed ventricular fibrillation, ventricular tachycardia, and ventricular fibrillation as well. And
That is
ventricular fibrillation
after verapamil.
after getting verapamil. So ventricular, but so far they witnessed. We were not there. The medical officers, emergency medical officers were there. So no cardiologist at the time of giving CPR or verapamil. So this is one thing. So it is not witnessed properly.
So what is the age of the patient? Whether the patient had got the cardiac disease, previous known cardiac disease?
No, no cardiac disease previously. A patient was 68 years.
So I think everything happened because of the bradycardia related events. That is the junctional, that is the atrial escape, VT, everything can be explained by the bradycardia, and bradycardia due to the verapamil injection.
That can be said. So the last ECG, 58 years, male, hypertensive diabetic, patient came in ventilator. In CCU, there was no pulse, no blood pressure, SpO2 92% on 100% oxygen, FiO2, and CV line given, inotrope started, and then BP 100/60. And this is the ECG. And definitely this is ischemic, no doubt about it. And then we did the echocardiogram. Echocardiogram showed bedside, it is 25 to 30%. And where is the disease? We did intervention later on. It is whether it is severe TD, left main disease, LAT proximal occlusion, or say proximal occlusion.
So should be global, that is the global STT changes with positive, that is the ST elevation in AVR.
Right, sir.
These all suggest that is the either left main or left main.
So maximum in favor of severe TBD, and left main disease few, 33%. And also LAD proximal disease, no one answered about RC proximal occlusion. Right, sir. This is actually patient is blood pressure was not there, severe.
That is patient was in shock.
Shock, right, sir. Definitely. And we did, we could not get the RCA ostium. That is why we did not, but actually we don't want to lose the time, as we know RCA seen a bit. That is why we are not going to RCA to see total RCA, but patient is in ventilator and time is short. So we have decided already the patient should have left main disease. So we, you can see the thrombus here at the bifurcation.
But
Here there
engagement
is a
seems
thrombus.
to be osteal disease.
And the patient all through left main disease is severely diseased. Total left. Total left main is
From
severely
ostium
diseased,
to
and there is a thrombus at the distal bifurcation.
Yep.
Distal bifurcation.
There is no regurgitation of contrast while you are
Right.
injecting.
Severely diseased, totally severely diseased left main. So we are doing everything rapidly so that at any moment patient might go into cardiac arrest again. So we don't want to take the time, but we try to thrombosuction because we don't want to dislodge thrombus anywhere, because patient thrombosuction done, and then we dilated. Everything was for few seconds only. We did not. We always give breath time, for enough breath time, so that there should not have any cardiac arrest. And Alhamdulillah, during the period there was no cardiac arrest. We have taken stent covering left main ostium to LAD. Ostium covered, and that is inflated, everything for a few seconds only, and it is quite good. And we did not try to negotiate the LCX because there is TME3 flow, and patient was blood pressure was going up on the table, and patient sent back to CCU. And patient on CCU, this is the first ECG post PCA, definitely much improved all over. And in the second day, we did echocardiogram, and it is LVF increased from 25 to 32. It is 50%. And patient on the second day, patient was extubated. And thank you, sir. Thank you for.
Rafique, did you plan for PCI to LCX on later dates?
No, patient have visited me in the few days back, and patient is totally fine, does not have any symptoms on he's on regular walking. He does not have any symptoms still. So we're not planning to put any stent in the LCX ostium. Or LCX ostium a bit pinched, but TB flow is fine.
Okay.
Whether it is necessary to put in a stent there, but it would be difficult because then it is stent should be given in the tap. Otherwise,
yeah.
And that was a life-saving procedure, not to make everything good enough. Just life-saving procedure.
Well done. Well done.
Thank you, sir. Thank you, sir.
So what route you use, that is Shafique, the femoral or radial?
Radial route. Radial route, I use radial route, but femoral route is one of the issue, but I choose radial route still.
In elderly patients, sometimes radial route becomes cumbersome to manipulate the catheters.
That is why I could not hook RCA properly.
Tortuosity
I
of
did not
the
try as well.
subclavian
Because
artery.
time is life.
Yep. So in that case, femoral route would save you more time.
All right.
So Shafique, again, what was your anti-platelet protocol after the procedure?
Patient was given on ticagrelor. We did not, because of 68 years. So prasugrel is one of the good choice, but we have given ticagrelor and ecosprin, aspirin.
Tushar.
Thank you, Dr. Abdul, sir, for your nice and very practical ECGs. These are the ECGs which we see very often in our clinical practice, and many a times, not only the trainee fellows, but also the consultants get confused. So
Tushar.
before the end, I'd like to request Professor Abdul Chowdhury to share his views on this presentation.
Tushar.
Sir. Hello.
Hey, Tushar.
Sir.
Can you connect the Dr. Benjir Belal Khan, Brishti? He had a comment on the chat box.
Kamal bhai, can you connect that?
Is there Dr. Benjir Belal Khan, Brishti? I think it is difficult to connect.
He might have left.
She left, sir. 9-2.
Okay. I'd request Professor Abdul Chowdhury, sir, to share his view on this presentation.
শফিক সবসময় ইন্টারেস্টিং ইসিজি নিয়ে আসে, আজকে তাই করেছে। সবচেয়ে এনিগম্যাটিক ছিল যে হাইপার মানে বিগ টল পিকটি ওয়েবগুলা দিয়ে, যে এটা কেন এক্সপ্লেনেশন কি সেটা কি আমরা জানি না। দেখুন এটা কি ইসকেমিক অরিজিন, ভলিউম ওভারলোড, নাকি হাইপারক্যালিমিয়া, ওই ইসিজি দেখে বোঝার পায়নি। এবং প্রত্যেকটা পয়েন্টই কিন্তু দেখা গেল যে কোনটার সাথেই ওটা মিলল না। এটা খুব ইম্পর্টেন্ট জিনিস। আর লাস্টে যে ইসিজিটা ছিল এটা হলো প্র্যাকটিক্যাল, যে এই ধরনের ইসিজিতে if you want to save the patient, you have to take the patient to the cath SAP as soon as possible and do the proper thing. He has shown beautifully how they have been able to save the patient. That is very nice of him. So seeing this kind of ECG in a peripheral situation where you do not have the resources available, you are in jeopardy. At least you can tell the patient's family what they are facing, what is the likely outcome. If we know and you tell them this is the outcome, this much we can do, this we cannot do because this needs to be done in a center like this. At least they can have some explanation and you feel more secure in your dealings with the patient's family. There's something our junior doctors should be more aware of. And seeing this type of ECG and sending the patient, only referring the patient to a higher center, that doesn't actually speak highly of you. You should explain them this is the situation. I'm going to do this, and this. In a peripheral situation, you can give antiplatelets, you can give hydroxystatin, you can give IV low molecular heparin, because unfractionated heparin, unfortunately, is not available in the peripheral part of the country. But low molecular heparin is available. That you can IV. The patient is in shock. And tell them what they need to do. We need to develop centers around the country where emergency PCI, primary PCI, rescue PCI can be done. Then that will be really good for this country. Shafique, you just bring into our awareness what sort of problems, what sort of deficits we have in our dealings with the giving service to the patient. Thank you.
Thank you, sir. Thank you, sir.
Thank you, sir. And before conclusion, I'd like to request Professor Atahar Ali, sir, to have his view on this presentation and conclude the session. Professor Atahar Ali, sir.
না থ্যাংকস তুষার, থ্যাংকস ডক্টর শফিক। রিয়েলি শফিক অলওয়েজ হচ্ছে ওয়াদুদ ভাই যেটা বললো, মানে ইজ এ গুড প্রেজেন্টার এবং ভেরি নাইস কেস সিলেকশন করে এবং খুবই চার্মিং এবং খুব ব্রেন স্টর্মিং ইসিজি শো করে এবং এই জন্য খুব ভালো লাগে আর কি। শফিক, থ্যাংক ইউ ভেরি মাচ ফর ইউর এক্সেলেন্ট প্রেজেন্টেশন অ্যান্ড শোয়িং দ্য নাইস ইসিজি। এবং লাস্ট কেসের জন্য রিয়েলি লাইফে যদি কেউ একটা মানুষও এরকম বাঁচাতে পারে, আমি মনে করি যে তার লাইফে অনেক কিছুই করা হলো। শফিকের এই কেসটা ওরকমই একটা কেস ছিল। ইট ওয়াজ জাস্ট এ চ্যালেঞ্জিং ওয়ান, যে এই পেশেন্টটাকে সেভ করা আর কি। থ্যাংক ইউ শফিক।
Thank you, sir. Thank you, sir.
বিদায় নেই আতার ভাই। আসসালামু আলাইকুম।
Assalamu alaikum.
আল্লাহ হাফেজ। গুড নাইট।
Good night.